Hello and welcome. I'm Jim Carroll. I'm the CEO of the diaTribe Foundation. Thank you for joining us. Our conversation today is about some truly exciting advances in the treatment of type 2 diabetes, new therapies and virtual care models that produce both a dramatic decrease in A1C and significant weight loss. These developments have led to a shift in the goals for people with type 2 diabetes and have raised the possibility that remission of this disease is not only possible, but attainable. And now I'm honored to introduce our moderator, Dr. Alan Moses, who will lead today's discussion. Trained as an internal medicine and endocrinology, Alan has had an illustrious career, which has included being a professor at Harvard Med School, chief medical officer at the Joslin Diabetes Center, the global chief medical officer at Novo Nordisk, which he retired in 2018, I think. He's now an independent consultant in the pharmaceutical and biotechnology sector. And diaTribe is extremely fortunate to have his knowledge, his expertise, his passion, his dedication as the chair of our board of directors. So now it's my pleasure to turn the microphone over to Alan to facilitate today's panel. Alan?
Thanks so much, Jim, for the kind introduction and for the opportunity to be a part of diaTribe. On behalf of diaTribe, welcome everyone. In the past few years, and even in the past few months, we've seen some great advances in treating type 2 diabetes, both medications and lifestyle interventions that allow people with type 2 diabetes to increase the amount of time that their glucose levels are within a defined target range called time in range. More time in range improves average glucose levels as measured by hemoglobin A1C. We're fortunate today to have three outstanding diabetes physician scientists help us dive into rethinking the approach to treating type 2 diabetes to improve quality of life and medical outcomes. Let me introduce them alphabetically, but first a disclaimer. I serve as a consultant for several early stage companies developing therapies for both type 1 and type 2 diabetes, and I also serve on an advisory board for Virta Health. So first, Dr. Vanita Aroda. Vanita is an associate professor of medicine at Harvard Medical School and director of diabetes clinical research at Brigham and Women's Hospital. Since moving to Boston a few years ago, Dr. Aroda has established herself as one of the leading diabetes clinical investigators in the country. She's a tireless proponent of patient-centered care and serves on the clinical practice committee of the ADA. Importantly, for this discussion, she also serves on the International ADA EASD consensus group for the management of hyperglycemia and type 2 diabetes. Vanita, thank you for joining us.
Thank you so much, Alan. It's such a privilege and honor to be here, and thank you to diaTribe.
Dr. Leonard Glass, Vice President of Global Medical Affairs at Eli Lilly and Company. Before joining Eli Lilly in 2004, he held a faculty position at the University of Miami, where he studied insulin resistance and mechanisms of insulin sensitization. At Eli Lilly, Dr. Glass has held positions of increasing responsibility that have spanned early drug development to leading diabetes medical affairs in the US. For the last 2 years, he has led the Lilly Global Medical Affairs Organization and is well positioned to help all of us learn more about the exciting molecules that Lilly has developed for the treatment of type 2 diabetes. Welcome, Leonard.
Thanks, Alan, and thanks, diaTribe. It's great to be here.
Last but not least is Dr. Robert Ratner, a longtime friend and colleague. Dr. Ratner now serves as an advisor to Virta Health after having served for 2 years as Virta's chief medical officer. Dr. Ratner is probably best known for his 5 years as the chief scientific and medical officer of the American Diabetes Association, where, based on his extensive experience as a diabetes clinician and investigator, he moved the association in new directions. Bob has an illustrious career as an NIH-funded clinical investigator and perhaps is best known for being the principal investigator of the Diabetes Prevention Program, or DPP. I personally look forward to a spirited, inspirational, and educational discussion. So let's kick this off directly with questions to the panel. We're going to start with the role of weight loss in treating type 2 diabetes. There are now more ways of treating type 2 diabetes than there have ever been, including new medications, virtual coaching to promote lifestyle changes, and advances in bariatric surgery. Let's start our panel by talking about the relationship between excess weight and specifically an increase in maldistribution of fat cells and the impact of excess fat on diabetes control and the role that weight loss might have in achieving better outcomes for people with type 2 diabetes. Bob, let's start with you. You've been on the forefront of treating type 2 diabetes for decades. Now we're witnessing a seemingly new debate about whether the primary target for treating diabetes should be weight control or the control of blood glucose. Can you help us understand the role excess fat plays in many people with type 2 diabetes? And how do you view the approach of targeting weight loss as a primary means to treat type 2 diabetes?
Well, thank you, Alan, for both the question and the invitation, and thanks to diaTribe for hosting us. I think it's important to realize that not all obese individuals have diabetes. Only about 20% of obese individuals actually become hyperglycemic. It's also important to realize that not all people with diabetes are obese. So it's a necessary but not sufficient, or sufficient not necessary condition, which means we need to be addressing each individual as an N of one. And depending upon what's going on, deal with that. All type 2 diabetes is beta cell dysfunction and decompensation, an inability for the beta cell to make insulin sufficient to overcome any resistance that's there and achieve the goal. So what one really needs to do is to understand what's the major problem in the person sitting across from you in the examining room. If they are markedly hyperglycemic and skinny, then what you need to do is you need to start insulin and be concerned about type 1 diabetes. If they're not skinny, they may still have LADA, latent autoimmune diabetes of the elderly, and they are still going to require insulin. If, on the other hand, there's clearly obesity with maldistribution of fat, as you mentioned, with abdominal fat, pericardial fat around the heart and in the liver, then weight loss can have a significant impact. So what we're really trying to do is to bring the beta cell back into a compensated state in which it's able to make enough insulin in order to control glucose.
So you're suggesting that this counterplay between insulin resistance, which you're alluding to with the pericardial, intramuscular, intrapancreatic, hepatic fat, and the beta cell itself have to come into balance in terms of achieving what we would call normal or non-diabetes glucose levels. Is that right?
Exactly. And the question is, what is the beta cell function? And we don't have real good ways of measuring that in a clinic. We can do it in the lab, but not in the clinic. So it becomes a clinical judgment that each clinician is going to make with each individual patient.
So I want to get back to the second part of the question I asked. And do you think then that targeting weight loss for those individuals who have the combination of excess and maldistribution of fat should be the primary means to treat type 2 diabetes?
It should be a means of treating type 2 diabetes. If, in fact, the glucose levels are only mildly elevated, then one can make the argument that it's the primary means. But even if the glucose levels are very high, and the decision is that you need to go to pharmacologic therapy, the institution of lifestyle intervention is absolutely critical. Right. What we know from every study that's been done is that if you use drugs to improve glycemic control, the weight tends to go up. Part of that is that the simple fact that you're no longer peeing out glucose and peeing out calories. You're retaining them. Right. So it's important to have a lifestyle intervention in all circumstances of diabetes, whether you want to call it primary or conjunctive. That's free for everybody to decide.
All right, so let's move on. Vanita, do you believe that the newer therapies that have a significant impact on weight, as well as glycemic control, like Tirzepatide, which we'll come to in a moment, and semaglutide, should change the way that clinicians approach the treatment of type 2 diabetes? And is it happening? And if not, how can we accelerate a change in approach so that more individuals who might benefit will indeed benefit?
It's a great set of questions, Alan. And I mean, if you look at our guidelines over the years, the early set of guidelines with type 2 diabetes really just focus on the single dimension of glucose. And if the glucose was not at goal, start on this medication, then add another medication, then add another medication. It really did it. It was a very singular look. But now with all the tools that we have, from lifestyle approaches to surgical approaches to pharmacotherapy approaches, we actually have medications and tools that address both glucose and weight, probably at par levels. So the evolution of the guidelines over the years is now saying, you know what? No two patients are alike. Let's put the person at the center, understand who is in front of us, and consider the person's goals in front of us, with our own goals being of helping them achieve their own glucose control goals and weight control goals and a risk of cardiovascular disease goals. So it's really now more of a holistic picture with the tools available to be able to address the whole picture and not just a single aspect.
So that sounds like more than a 15-minute interaction with a patient with diabetes.
Well, it's a different quality of interaction. Whereas again, before we were very tunnel visioned. I think now we've gotten better at taking a look at the whole picture and thinking about matching the medications or matching the approaches to the goals that we have. But are we there yet? No, we've got a long way to go.
Okay. All right. Thank you. I think you've both set the stage nicely for the next question, which goes to Leonard Glass. Tirzepatide recently was approved by the FDA as an adjunct to diet and exercise to treat type 2 diabetes. That's the label. That's the indication. Can you explain what Tirzepatide is for the audience and how it differs from a pure GLP-1 receptor like Lilly's dulaglutide? And what did the clinical program for Tirzepatide reveal that has excited many clinicians about its potential role in type 2 diabetes, both in terms of glucose control and weight loss?
Sure. So Tirzepatide is Lilly's new, and it's the first and only FDA-approved GIP, GLP-1 receptor agonist, which is delivered in a once-weekly injection. And what it is it's a single molecule that acts on the GIP and GLP-1 receptors in the body, which GIP and GLP-1 are naturally occur in what we call incretin hormones, and Tirzepatide acts on those receptors. Incretins are secreted in response to nutrients when we eat, and that helps control our blood glucose and our metabolism. And GIP is also responsible for a great majority of that incretin effect. So we are very excited about this new medication because it's also a new class, which we haven't had a new class of therapy for treatment of type 2 diabetes in about 10 years now. And in our clinical studies for the study of type 2 diabetes in the SURPASS program, what we saw was that Tirzepatide actually was superior with regards to hemoglobin A1C to every comparator that we had in our studies, including semaglutide, which is a GLP-1 receptor agonist. And it was superior with regards to hemoglobin A1C. On the lower dose, Tirzepatide was decreased hemoglobin A1C by about 2%. Our higher dose, it was about 2.3% compared to semaglutide 1 milligram, which was about 1.9%. So that, of course, in the treatment of glucose, which is what Vanita was referring to, just if we just focus on glucose, that's very exciting by itself. Of course, we're also very excited because of the weight change that we also were able to see with regards to in the study in type 2 diabetes in this program, where we saw significant weight reductions as well with Tirzepatide.
So we've got a powerful new agent in our toolbox to treat individuals with type 2 diabetes. And I think that's terrific. But I want to turn to another modality, and that is back to you, Bob. You're a medical advisor and former chief medical officer of Virta. Can you describe what the Virta Health platform looks like and why it differs from prior lifestyle interventions for type 2 diabetes? And more specifically, is there something, in your opinion, inherently different, maybe better, about a ketogenic diet for people with diabetes as opposed to other nutritional approaches that produce significant weight loss and could potentially lead to diabetes remission?
I was attracted to Virta because of the concept of continuous remote care. We spend maybe 40 minutes, 50 minutes a year with our patients. That just doesn't work for chronic disease like diabetes. So having a continuous remote care model allows health coaches, nutritionists, and providers to interact much more frequently with their patients. The intervention that Virta had developed was a well-formulated ketogenic diet. And like many physicians, I went into it quite skeptical about the value of that well-formulated ketogenic diet. It's essentially a Mediterranean diet in which you take out the pasta and take out the bread. We drop carbohydrate to very, very low levels. And the data were demonstrative. People liked it, people could stay on it, and that's the critical issue about any nutrition intervention. What you tend to see with any lifestyle intervention is weight loss over the first 6 to 12 months, and then maybe a stabilization, but then a substantial weight regain. And part of that is because it's hard to stick with a diet. The direct trial was a very, very low calorie diet that worked. The problem was that the durability disappeared because people couldn't sustain it. We've looked at 5-year outcomes in our clinical trial with a 50% retention rate at 5 years. And at 1 year, it was over 80%, at 2 years, over 70%. So people can actually follow this. The effects are remarkable. We had an average weight loss of 9 kilos, about 20 pounds per person at 5 years. And the interesting fact was that 20% of individuals at 5 years had normal hemoglobin A1Cs on no medications at all. So the sustainability and the durability is really what differentiates this approach from very low calorie diets or the DPP look ahead type of diet, which wasn't quite as sustainable. Now, one can argue that this was a clinical trial, and so we had a select patient population and everybody wanted to do well. And that's a fair criticism. But we've also been taking care of patients within the Veterans Administration. We enrolled over 400 individuals. Our 1-year retention rate in VA patients was 73%. Our 2-year retention in VA patients was 57%. So even these unselected populations can actually do it and stick with it. That's what differentiates this program from Weight Watchers or Noom or any of the other lifestyle programs. It's the fact that people stick with it.
I mean, those are obviously impressive, not for everybody, right? I mean, they are individuals who go on self-select by definition, the opportunity to participate in the program.
Absolutely.
But the results are not to be discounted. I mean, they're very impressive. Now let's move on to another even sort of more aggressive approach to weight reduction, and that's bariatric surgery. So, Vanita, you want to tackle the options that are available for bariatric surgery and why some of the procedures are more efficacious than others? And I think we
Yeah.
need to tell our audience whether there are risks to this, and you think more people might benefit from this approach than currently are receiving it.
So the one thing I tell every patient is whatever pathway we go down, I want you to picture what you think you can stick with a day from now, a month from now, a year from now, and 10 years from now. Because again, there's a number of approaches to try to get the weight off early on and can be successful at it. But what really counts is the durability of the effect. And so when we think about bariatric surgery, the advantages there are that we can actually reduce the weight by a greater magnitude. And what we've seen in many of the studies is that the higher magnitude of weight loss often translates to better outcomes later on. And by outcomes, I mean lower likelihood of the diabetes, or higher likelihood of quote unquote remission of diabetes. And I'm sure we'll get into that discussion. And there's some observational data suggesting, again, better long-term control and lower risk of longer-term complications. But is it for everyone? No, this is a very personal decision. Bariatric surgery is a surgical intervention. It alters the anatomy of the gut. There are different types of surgeries. There's probably most well-known are Roux-en-Y gastric bypass, so making the pouch of the stomach smaller while bypassing some of the intestine where the nutrients are absorbed. There's sleeve gastrectomy, there's laparoscopic banding. And it turns out that, when you bypass areas of the gut, you actually bypass the absorption of calories, which leads to a net calorie deficit. So there are lots of different ways and approaches. Is it for everyone? No, it's a very personal decision, and every procedure has risks.
Yeah, so basically what we're doing in this approach is creating a situation of malabsorption of some nutrients, right, to promote weight loss, and it's effective. But then people stabilize. They don't just continue losing and losing and losing. What about the likelihood of weight regain? Is that, even with much of the gut bypass and some of the procedures, is there a risk that people will gain weight over time and redevelop their diabetes?
So you're going to hear me say this one over again. Bariatric surgery, like everything else, is one tool in this big toolbox that we have. And there are ways where people gain the weight back. So for example, you'll see the greatest weight loss after bariatric surgery in that first 6 months to 1 year. And then you'll start seeing some weight regain. Why is that? Because the bottom line is the net calorie intake versus the net calorie expenditure. And so some ways to kind of get around the calorie deficit induced by bariatric surgery are by drinking high-calorie milkshakes that go through the gut very easily, and the calories get absorbed. So there is some level of weight regain, and it depends on the individual. Some people gain a lot back. Some people are able to sustain it.
Okay. Before we get specifically into the definition of remission and how likely it might be to achieve, I want to go back to Leonard for a minute and a question about Tirzepatide. And that is, can you separate the direct effects of the molecule on glucose control from the additional benefit that comes from weight loss, vis-a-vis weight loss and glucose control? And do you have any data yet on what happens when people stop the drug?
Sure. So that's a great question. Of course, like I mentioned before, in our clinical program, we also were very excited by the weight loss that we've seen. Now, Tirzepatide is not approved for chronic weight management, but we know that diabetes and obesity, like Bob was mentioning before, they're distinct diseases, but they're very interlinked. Of course, they're distinct but related. And for example, for Tirzepatide right now, we haven't been able to separate the two. But we have studies. We're right now looking at it. We've got some phase 1 studies, mechanistic studies, where we've seen that Tirzepatide, in fact, does cause improvements in insulin sensitivity, increases insulin sensitivity. It also suppresses glucagon. secretion. So we've seen those effects. We've also, in addition, in that phase 1 studies, in addition, we've seen that it significantly reduces total fat mass and as well. And as compared also with, for example, semaglutide in that study, in that phase 1 study. So we've seen all these individual changes, but to be able to separate them has been very difficult right now, and we don't have the answer to that. With regards to your second question, which is, I think you said, if I'm correct, is have we seen what happens when we stop the medication and what happens? We haven't done studies to look at what happens when we stop the medication, but based on the information that we have in the past, until now, the only incretin medications available have been GLP-1 receptor agonists only. But when you stop those medicines, we know that you regain the weight. So there's nothing, and the glucose comes back up. So there's nothing to indicate at this time that stopping it would prevent it from coming back up.
So we haven't yet found the magic drug to make diabetes go away. But that brings us exactly to the discussion of the term remission, which is being utilized a lot more now, certainly in the medical literature and at conferences on diabetes. So let's spend a few minutes talking about it. First of all, what does the term mean to you, and what does it mean to the consensus conference? How likely is someone with type 2 diabetes to achieve it? And are there certain characteristics that suggest an individual will achieve remission? In other words, can you look at a patient and their data, and I don't mean just their laboratory data, but how long they've had diabetes, their weight, and their family history, and predict who might have a greater chance of going into remission? And then, most importantly, how long can remission last? So let's start with definition, go to any characteristics, and how long it might last. And Vanita, I'm going to start with you, have Leonard follow, and Bob, you can clean up on this. And you don't have to repeat what the other person says, but if you want to counter what they're saying, please do so.
So the American Diabetes Association was part of an international consensus that defined what remission in diabetes looks like. And I really think it was more for just making the field very clear in terms of the semantics and definitions, because this term is being used pretty frequently. And the definition used was, glucose levels not in the diabetic range, so an A1C of less than 6.5%, or a fasting plasma glucose less than 126 if the A1C was not reliable, for at least 3 months without any therapy, and following an intervention aiming towards remission. So that's been the kind of purest definition of remission. But what does it mean for a patient? And I think that's what it comes down to in terms of our responsibility of talking about remission. For patients newly diagnosed with type 2 diabetes, a reasonable goal might be remission. Hey, can we turn back time? Can we reverse the course of this disease with a number of interventions that we have? But I think it's also really important to not dangle it as an absolute, because patients who have type 2 diabetes are at risk by the natural course of disease of progressing to type 2 diabetes range once again. So those are just a few kind of quick thoughts.
Super. Leonard?
Well, I agree with a lot of what Vanita said. Of course, the work that I do is to try to, of course, ultimately cure diabetes. That would be my goal. But in my professional opinion, remission as a term, I think it's complicated, because what we want is to be able to achieve first normal blood glucose, normal weight. We want to get to that to prevent the complications that occur with diabetes and related conditions, heart disease as well. And so we want to prevent this. And we know that these patients have a propensity, they'll have genetic predispositions that may cause this. We know that there's other conditions in the environment. So there's a lot of things going on. So I think for me, the goal would be to try to prevent them from developing the complications and to maintain a normal blood glucose and normal weight, which it would be my goal. I think in the future, we'll have other therapies. We'll have cell-based therapies. We'll have DNA-based therapies maybe, and that's many years to come. But for now, I'm looking to try to prevent them from developing complications.
I think that's certainly a worthy goal. So are you then, you skirted a little bit the question of remission as a term.
Well,
and
because
I'm gonna hold your feet to the fire.
Yeah, so of course, these are definitions that came up, and based on what we know at the time, I don't know that right now you can stop a therapy and then expect patients people not to either regain the weight or have their blood glucose come up. It may hold up for a little bit, but eventually I do believe that it will come up again with current therapies. But our goal should be to try to have them live a healthy lifestyle with to be metabolically healthy. And that's what I believe we should try to achieve. And whether you have to do it by taking a medication, I think that's still a very good goal if the risk benefit of that medication is still positive. So that's where I am currently, is what I believe.
I think that's a very fair answer. Bob, you've been involved in this, thinking about the prevention of type 2 diabetes earlier in your career. What do you think about this term remission and whether it can be achieved and what it means if it is achieved? We all agree, I think, that there's a risk for anybody who achieves remission because they got diabetes in the first place.
Yeah.
And so the other thing I find curious about the definition is the goal is an A1C of less than 6.5. The range of 5.7 to 6.5 is not normal. We call that a different condition. We call that pre-diabetes, where there's a very high risk of progressing. So do you want to put that into context as well in terms of your impression of remission and who can develop it?
So this has been an ongoing discussion at the ADA and EASD for years. John Buse actually produced the first, quote, definition of diabetes remission that nobody had any faith in whatsoever. There have been multiple meetings over the years to try and do this. And the most recent consensus conference actually started looking at data, which is kind of nice for a change. The issue of, can you identify individuals who may be able to go into remission, simply accepting the definition for the time being. Within bariatric surgery, you can. Individuals who are on insulin or who have had diabetes for longer than 8 years have a very low remission rate. They still respond, but they don't go into remission. In the direct trial, which was a very low calorie intervention, what you saw was remission at 1 year that then dropped by about close to 50% at year 2. So this comes to your point, Alan, of what's the magic about 3 months? The magic about 3 months is to try and give a beneficial label to some intervention and ignoring the fact that there is natural weight regain following bariatric surgery, following most lifestyle interventions, following most medical interventions. So I agree with you, remission is a problematic term, but it's trying to match what we do in cancer. We don't talk about cure in cancer unless you've been in remission for 5 years. Not 3 months, we're talking about years. And I think that that's going to be critical to really getting to the point of how do we talk about diabetes. I happen to agree with you that the level of glycemia is important because of the anywhere from 7 to 11% progression from pre-diabetes to diabetes. I think it would have made more sense if they talked about normal glucose, fasting's under 100. A1C of less than 5.7. But I wasn't part of the consensus group, so I didn't have much to say about it.
Yeah, so they missed out on having that input. And I'll just say, for the sake of the audience, whether you're a clinician or a person with diabetes, you're going to hear this term remission. And it's an important term to talk about because we now do have modalities that can allow people to achieve it, at least for some period of time. But Leonard used the word cure. Remission is not a cure. And people with the genetic predisposition and the lifestyle factors, some of which they can control and some of which they can't, that predispose to diabetes, are still going to be sitting with those risk factors. And the likelihood of going back to diabetes. However, really good glucose control for however long is a good thing in terms of long-term complications for diabetes, cardiovascular disease, as Leonard said. So this concept of achieving the lowest possible glucose most safely is something that we should begin to aspire to. And that's going to bring me back to Bob in terms of the Virta program, because improved glucose with deprescription of medications is a sort of a primary goal of the Virta program. How does the program do this? I mean, you talked about the ketogenic diet, but what do you think is the most important component? Is it the diet, or the diet being reinforced by the frequent patient-clinician interaction?
You can't separate the two, Alan, because of medical necessity and safety. The way that this works, and many of our listeners probably have personal experience with this, we substantially lower carbohydrate content in the diet. If you do that, and we go down as low as 30 grams per day, your glucose levels precipitously fall. Now, if you happen to be on medication, that needs to be adjusted down in order to avoid hypoglycemia. Now, it's the low carbohydrate intake that lowers glucose acutely. We can follow compliance with the diet, adherence to the diet, by measuring ketones in the blood. And patients in the Virta system are measuring both glucose and ketones on a daily basis. These data are then transferred back to the health coach and to the provider for adjustments to be made in medications. So low carbohydrate intake lowers glucose precipitously, which requires deprescription of medications, which then results in further weight loss, which then results in further fall in glucose. And you're now in a virtuous cycle where the weight's coming down, the medications are coming down, and the glucose level is coming down. So it's that virtuous cycle that really allows this to work. Now, one of the problems with many other lifestyle interventions is that people don't see acute effects, so they give up quickly. Individuals in a well-formulated ketogenic diet are seeing falls in glucose on day 2. They're seeing decreases in medications on day 1 or day 2. They're seeing falls in weight within the first week. And so this success breeds adherence. And people see the beneficial effects, so they stick with it.
So, Vanita, as a clinician and one practicing in an academic center that doesn't necessarily have the resources to do what the Virta intervention does, do you see any pitfall in terms of integrating this approach into a person's primary care? I mean, how do clinicians tend to respond to somebody else, somebody outside their orbit, making recommendations on a frequent basis? Is this something we should really strive to achieve?
I mean, it's a tough question, Alan. I mean, you commented on it earlier in the hour that, how much can we accomplish within 15 minutes? And there's clearly a lot of expertise that Bob has shared with us that develops over time that our network of clinicians really don't have at their fingertips. So I think that's a real challenge in terms of healthcare in general. Is there's not one size fits all. You know, the Virta diet that you described sounds highly effective, but there are lots of different factors at the individual level. There are cultures to deal with. There's not a one size fits everybody. So I think the bigger question is, how do we put all of these options on the table and best educate our colleagues and our patients with diabetes on what might be the best option for them? And that will take time, and I think that will take a rethink of how we currently deliver healthcare.
Yeah, so if I can sort of summarize where we are at the moment, I think we all agree that there are new tools available, and those tools are much more efficacious than they were previously. I mean, bariatric surgery has been around for a long time, but new procedures have made it a little bit safer and perhaps more efficacious as well in terms of metabolic control. New medications, GLP-1, the dual agonists, are clearly more potent in regard to glucose control and weight loss than prior agents. And they have some other benefits as well, not proven for all of them yet in terms of cardiovascular disease. Ketogenic diets in association with a virtual care model are clearly effective for those individuals who subscribe to it and follow it. And there's a high retention rate, which is terrific. But I think each of you has stated in one way or another that we really have to individualize the treatment for the specific needs, culture, environment of the individual with type 2 diabetes. And that as clinicians, we have to be far more open to options that may be particularly beneficial for one individual versus another. And the only way you can do that is by probing them and understanding who they are as people. And that's one of the most difficult challenges in diabetes treatment today, particularly in primary care, but even in specialty care, because clinicians don't really have the time to dig into what's best for their individual patient. If there's anybody who wants to push back on that, please do. But that's my own personal bias after many years in practice and following this field rather closely.
Yeah, that is the gap. And if you think about our healthcare systems, who actually owns that knowledge and expertise? So here at the Brigham, we have a comprehensive weight management program where they will go through some of the different options, but who has access to all of these programs? I mean, I think, again, we're going to have to rethink how we're doing things.
I want to come back to the virtual care model, the lifestyle intervention with virtual care. Bob, and I think you really alluded to this, but I want to ask you specifically. Do you believe that significant enough weight loss and improved glucose control can be achieved to reduce the chances of diabetes complications in most patients without taking medications?
I need to clarify what medications are for. For glucose lowering medications, yes, I think you can get away from using meds specifically to lower glucose. But what we've learned in the last 7-8 years is that medications that we've used for glucose lowering have pleiotropic effects. I don't think any of us would want to see the discontinuation of an SGLT2 or finerenone or a GLP-1 receptor agonist in our patients who have underlying renal disease or who have underlying congestive heart failure and heart disease. They have independent effects. When you look at the Look Ahead study, which was specifically weight loss and its impact on diabetes complications, it was essentially a failure. It didn't reduce mortality, cardiovascular events, or renal disease. So I think we go back again to the concept of treating each individual patient according to their needs. Even within Virta, where our goal is to deprescribe medications. If a patient has underlying heart failure or diabetic kidney disease and they're on an SGLT2, we don't discontinue it because we know there's no risk of hypoglycemia if we leave them on it with the diet, and we want the additional benefit in terms of renal protection and cardiovascular protection. So I'm skeptical that we're going to be able to eliminate all diabetes complications just with weight loss.
So
Please, Vanita.
I'll chime in as well. If we look at the long-term data in terms of reducing the risk of diabetes complications, which is why we do what we do, it really comes down to 5 different factors and markers. So 1 is glucose control, 2 is cholesterol level, 3 is blood pressure, 4 is kidney function, and 5 is no smoking. And that seems to be the magic wand where if we can achieve control of those risk factors and they all kind of cluster together through any number of ways, patients tend to have a lower risk of complications in the later years.
So I think if I can summarize again, what all of you are saying in different ways is that don't be afraid of medications, and don't let the term remission mean that you shouldn't take any medications for your diabetes. The goal is to achieve the lowest possible glucose you can safely with available medications, and to think about the other risk factors that, in combination with the dysglycemia, the abnormal metabolic profile of people with type 2 diabetes, increase the risk for renal disease and cardiovascular disease and cerebrovascular disease, among others. So new medications, whether they have glucose lowering effects or not, may be very beneficial even if your glucose has achieved a near normal level, as long as you're not developing too low a blood glucose, which is not a fair trade-off. So I think that's sort of where we stand. I have one quick follow-up question for you, Leonard, and that relates again to Tirzepatide and the clinical trial program for type 2 diabetes. We know that semaglutide was developed both for diabetes and for weight loss. Is Lilly also, for our audience, taking that approach with Tirzepatide?
Yes. So like I said before, Tirzepatide is not approved for weight loss, but we are actually conducting a large clinical program called the Surmount clinical trial program, where we are looking, and we've had conversations with the FDA for a weight loss indication. And we released data from the Surmount-1 study recently at the ADA, the American Diabetes Association meeting in New Orleans. We were very excited by the data that we saw there, and we continue to have conversations with the FDA to see how to move that program forward. So we are looking at it.
Yeah, I think this is a very exciting time for this intersection between overweight, obesity, and diabetes, because for the first time in, well, really in therapeutic, in medication history, we have agents that are highly efficacious and are remarkably safe compared to some of their predecessors that caused all sorts of issues that we don't have time to talk about. I want to shift gears again. I thank you all for the insights that you provided vis-a-vis remission and the approaches to glucose control and weight loss. But one of the issues that I think is really problematic for patients who are overweight and have type 2 diabetes is this issue of stigma. Do you think the increased focus we've just talked about on promoting or trying to achieve weight loss is going to decrease or increase the stigma that's associated with obesity and overweight? Vanita?
You know, I'm hoping that with the tools that we have, it can just be treated as an objective factor, as, you know, again, as a biomarker that represents a bigger picture for each of us. And so weight is an important factor, but there are so many historical, personal, social, cultural issues that go into the weight picture that I hope that the tools that we have allow us to have the more holistic conversations with patients that we should have been having this whole time.
So do you, let me reframe the question. Do you think the stigma associated with obesity, and there's no question that there is stigma, is more of a problem for the patient or the care professional in terms of approaching the excess weight?
I think it's both. Because you cannot address weight sensitively in a quick 30-second blurb. And you cannot give very, crude advice of, okay, you need to eat less and exercise more. It really entitles its own session and its own, holistic approach. So
and how do we do that?
Stigma at both ends.
But how do we do that?
So I think this is where, again, we have to rethink how we're delivering healthcare. This is where we think about a team approach to our patients, where we think about our extenders, whether it's in virtual health options or in our physical teams that we work with. But I'm curious what Bob and Leonard have to say on this as well.
As am I. Bob? Or either one.
Yeah, go ahead, Bob.
I think that part of the stigma is based on the perception, both of the patient and society in general, that it's the patient's fault. We now know that isn't the case. We know that there are hypothalamic signals. We know that there are inflammatory changes that simply change metabolism, and that it's not the patient's fault. And as Vanita said, I think that the new therapies that we have, lifestyle, pharmacologic, surgical, are now giving us far more effective interventions. And so if people, you talk to people who have had weight problems and they'll tell you they've been on 1,000 diets and none of them work. If they can find something that works, then their whole personality begins to change, because now they're successful as opposed to this perception of failure. And I think that's what the future really holds for us, is effective therapy, where we haven't had that in the past.
I think that's the key. Sorry, Alan, but I
was going to actually just turn that question exactly to you because of some of the new therapeutic agents that are.
Well, yeah, I think that stigma, like Vanita said, it's both. It's at the patient level, and then of course the physician or healthcare providers in general have had difficulty with this, because one, they don't have the time. The other, the therapies were not necessarily the most attractive. Either surgery is not a great option to present to anybody at the end of the day, and then when you go to diet, a lot of patients do in fact a lot are successful with it, but a lot are not. And then it becomes this issue. And if you don't have the time to have that conversation, it becomes very difficult, especially if you don't have the tools in your clinic. So one is the healthcare system. The other one is that luckily over time, we've had improvements in therapies, including surgery has become better, less risky than before, but nevertheless, it's still a surgery. And we've been able to identify new targets and new therapies that also deliver significant improvements in weight. And that, again, provides more tools and can help with that stigma. And again, at the end of the day, what you want to achieve is a healthy condition for the patient in general. It's not a question about whether, it's not what has become a beautification kind of issue. In the past, it was a stigma about that, but it's not about that. It's about being metabolically healthy, like I said before.
Exactly. So now we've got these new medications coming out. Some have been out for a while, new ones coming, and they're even more in development. Some at Lilly and some at other companies. That'll be very interesting to watch over the next few years. But one of the questions that comes up for individuals with diabetes, with or without excess weight, is what's the access like? Can they get it? Can physicians prescribe it? What are the costs? So how does Lilly approach that in terms of access, particularly for a new drug introduced into the marketplace?
Yes. So, of course, we understand how difficult it is for patients and families of those that have diabetes when they have to have access to all these medications and therapies. We are doing. We believe that the patient should have access, and we are helping to do that. Of course, Tirzepatide just recently got approved, so it's been just since March. So we're working right now with insurers, with health plans, healthcare organizations, and with providers in order to improve that access. And right now, for those patients that have commercial insurance, we at Lilly independently have a program where we have a savings card where patients can have the maximum out-of-pocket cost of $25. So that's right now what we are doing, and we continue to work, again, like I said before, to improve that access so that patients can get their medicines.
Bob, same sort of question in terms of the Virta program. I mean, not everybody has access to it. I believe it's sort of restricted by payer, right, in terms of access. What is the approach like, and how do you use social determinants of health and cultural differences to fit a person into the diet in a way that can be successful?
So you're right, Alan, that this is basically being done through employers, health plans, the Veterans Administration, but there is also the capability of self-pay. So anybody who's interested can get into it. But at this point, there are over 200 employers, there are over 20 health plans that are involved, and the negotiations with the VA are ongoing to expand it into the thousands. So there are a lot of opportunities. One of the things that we've discovered is that you have to individualize the diet as well. Now, the concept is simple: decrease carbohydrate. But that's very different if you happen to be East Asian or South Asian, or if you are Hispanic, or if you live in the American South. So trying to individualize these is critically important. Our nutrition specialists have literally developed adaptations mechanisms for each of these populations to say, okay, if you consider rice to be an inherent part of every meal, what do you substitute for rice? Well, riced cauliflower happens to be one of those things. Okay. For tortillas in a Hispanic population, what you do is you take the cheese and you fry it up into a tortilla, and you can do the same thing. So these are adaptations that go to the cultural needs of individual populations.
And I think we're back to this concept of individualizing treatment needs to take into account all of these elements, and they're so difficult to get in a cursory interchange with a patient. Yeah. So, Vanita, I mean, you must face this at the Brigham all the time in terms of the diverse patient population that I know you see there.
It's really challenging. What I like to think is that as clinicians, we are advocates on behalf of our patients, that we will take the time, or our teams will take the time to look at, what support is available. We actually have in our hospital a social determinants of health referral service. So, in addition to access and cost, there's food security. We've been talking about healthy behaviors, but not everyone has access to healthy, affordable foods. Physical activity is important, but not everybody has access to walkable neighborhoods. These are things that many of us take for granted. So it really does extend beyond just cost and access to the medications.
Okay, I've been peppering you with questions for the last hour. Now it's time to turn to our audience, and we've received a number of really good questions. The first one from our founder, Kelly Close, who, as usual, has some very insightful issues that she wants to bring to the fore. And I'm not directing this to an individual. I want you to, I'm going to toss this in the air and you go for it. There are actually 3 questions here, and they are: how do you prioritize therapy used for treatment versus prevention, realizing there's no regulatory indication for prevention at the moment? How early could therapy be used to keep patients well along those lines of prevention? And are there trials that show patients staying well for a long time?
I'll take a stab at the first one. So believe it or not, a lot of what we learn about caring for patients with type 2 diabetes, I think we learned from the diabetes prevention program itself. So in the stage preceding type 2 diabetes. So a couple basic tenets is what's important is the course over time. So if you look at someone's glucose or A1C levels at one point in time, that's only a single snapshot. But if you look at their course over time, you can actually catch when things are starting to progress or deteriorate. So even though we diagnose diabetes at an A1C of 6.5%, you can start seeing, okay, the A1C is 6, now it's 6.2, and that above 6.2, we start seeing an inflection point related to complications. Other key principles from the DPP are that even in that stage, 1 kilogram of weight loss translated to 16% reduction in progression. So we know that early intervention, even towards the cusp of diagnosis, will likely be beneficial. And then the very last tenet that we learned is normal glucose achieved during that prevention stage did translate to longer term reduction in complications. So it goes back to the same picture of all of these factors translating, better control of these factors translating to better controls in the later years.
And that gets back to, when should we be aggressive in terms of initiating therapy? I mean, we've long used this treat to failure model of starting a person on a drug, waiting till their blood glucose rises, and then adding another drug or substituting another drug, and you keep that progression until ultimately they're on insulin. I mean, that was the historical approach. I think many people have advocated for combination therapy early, but how early, and what should the goals be? Should those change now with the new agents that are available? Bob? Leonard?
So, Alan, I'll remind you that Benjamin Franklin a long time ago said that an ounce of prevention is worth a pound of cure. Unfortunately, our healthcare delivery system and the economics of that healthcare system doesn't put much value in prevention because the benefits take so long to see. It's a cultural problem there. Do we have data that shows that you can keep people well for a long period of time? Well, Vanita, you guys just published 20 years of the diabetes prevention program. The DCCT for type 1 diabetes has published 30 years of benefit. There's no question starting early is beneficial and you see long-term effects, but you have to wait 20 to 30 years for the economists to be able to demonstrate the difference.
Well, in addition, I like to add, though, you mentioned something, Alan, which is, again, therapies and the treatments have evolved over time. I think that's the other thing that we need to consider, because, of course, we sometimes our system is a little bit outdated. By the time we make decisions, new therapies have been already available for a while, and then we don't make decisions soon enough. So I think now we have therapies that, you mentioned hypoglycemia, that used to definitely be a bigger problem before than it is now. It's still a problem, but it's less. And some other complications, some other problems that came with therapies themselves have decreased. So we have to change our model. The model has to be able to evolve rapidly as therapies also evolve for us to be able to make those decisions. And of course, what Bob is saying with the healthcare systems also not necessarily supporting starting from the get-go, very, what you call aggressive. I probably is not aggressive, but more intensive therapy. would be also beneficial. And we do have the data that treating early prevents complications in the future.
Yeah, I think one of the great failings of type 2 diabetes therapy, specifically over the last few decades, has been this unwillingness to jump in with the most efficacious drugs early on. Now, some of those drugs have only been available for a decade or so, but nonetheless, we have that opportunity, and I think individuals with diabetes should look for that from their clinicians and be part of that dialogue. We have a lot of questions here, which are very pertinent, but we don't have time for too many more. Rita said, and we're going back to something we talked about earlier, that not everybody with type 2 diabetes is overweight. Bob talked about this very early on. What about, how do you approach those who are not overweight in terms of both lifestyle and medication approach? Obviously, they're not candidates for bariatric surgery. Bob?
That's when you begin looking for other causes of diabetes. If you've got someone who's thin, then you begin to look at issues like latent autoimmune diabetes of the elderly, looking at type 1 diabetes, looking at primary pancreatic disease or other drugs that may be causing hyperglycemia. And the glucose then becomes the major focus of your therapeutic intervention as opposed to the weight for exactly that reason.
Right.
I'll just add that, when we establish weight management goals, prevention of weight gain is also a goal. So even if someone is at their ideal, comfortable weight, prevention of weight gain is an important health goal. And you'll
particularly
see that
as we age.
Yeah.
Right, Vanita? Particularly as we age.
And while maintaining your muscle mass.
While maintaining your muscle mass, exactly. Yeah. If you have achieved good control with whether it be diet or bariatric surgery, I'm not going to talk about medication right now, achieving the lowest A1C with the realization that stopping the medication may be problematic. But if you're on metformin, is there a time when you can feel comfortable discontinuing metformin, which most people consider a reasonably safe drug, or should that just stay on as baseline and not be considered a big deal, if you will?
I think this is a time that's really in flux right now because we've never seen such effective therapies as we're starting to see. We always considered metformin as foundational therapy, that it probably has benefit in the long run. But if someone has a complete normalization of all of their biomarkers and glucose values, one could argue that, it's reasonable to stop it if you have it under control with other methods.
And then I would just bring in one bit of technology here. Vanita, you talked about A1C and it climbing from 6 to 6.2 to 6.4. What role do you think technology, specifically continuous glucose monitoring, may have as an early canary in the coal mine in terms of metabolic control, losing control?
So it's potentially super powerful because it puts control and knowledge and empowerment at the person's end, at the patient's end. Unfortunately, at this point in time, I think cost and access are going to be an issue because it's only covered for patients who are much further advanced in their diabetes, so people who are on insulin. But I think that's the potential pivot in what we can do as a society in terms of making a difference at the patient level.
Great. All right, I'm going to close the questions from the audience. Thank you very much for those really good questions, and thank you, panelists, for a great discussion. But I'm not going to let you off the hook yet. There's one final question, and it's sort of a summary of all we've talked about today, and that is, and I want each of you to take this on. You have 30 seconds. Do you believe that the majority of people with type 2 diabetes today can reasonably set an expectation of achieving and sustaining an A1C below 6.5. That is, an A1C below the clinical definition of diabetes, not prediabetes, but diabetes, be it with or without medications? And are there dangers in setting that expectation? Leonard, you're first up.
As an endocrinologist, I do believe that it is possible if we individualize therapy. It has to be a conversation between the patient and the healthcare provider, but new therapies allow us to get very close to normal with low risk, of course, depending on the patient. So I do believe it is possible.
Bob?
Cost and access limited. We've got an awful lot of people who don't have adequate access to healthcare, whether it be because of poor insurance, no insurance, or being in an environment that doesn't have access to health professionals. And then the cost becomes the critical limiting factor, even if you do have access.
All right. Vanita?
Feasible, yes, and in no way like we've ever seen before. So feasible, yes. Dangerous to set expectations, yes, based on everything that Bob just described in terms of really needing to understand the individual and the holistic picture.
And I will add to that, I agree completely with what all of you have said, but I'd add it also depends on where in the stage of diabetes the patient presents to you as clinician. I think the key for everybody listening to this, particularly on the clinical side, is start treatment early. You have the best chance of achieving a good outcome, and you have the best chance of sustaining that outcome for a long time, and you have the best chance for really impacting long-term complications from diabetes over a lifetime. The tools are there, whether they, we've talked about several of them. I think it's just an exciting time in diabetes, both for the science and for the translation of that science into the care of individuals who have diabetes. So, thank you all as panelists for great discussion, and thanks everybody who joined us for this delightful interaction. I want to thank the sponsors again, and especially Eli Lilly, who's a silver sponsor and whose name got left off the list. And Leonard would probably never sign off from this until I said that. But it's you sponsors who have made it possible for diaTribe to hold these learning opportunities to educate and empower persons with diabetes in order to improve their quality of life and their longevity. It's been a fun discussion. Bob, Leonard, Vanita, thanks so much for participating. Goodbye, all.
Thank you.
Thanks
Thank
to you,
you,
Alan.